So just like you have an insurance policy where you have a clear nominee, right? Insurance policy में आपको nominee बनाना पड़ता है, right? Whether it is one person or more than one person, you could say my wife or my husband gets all 100%, or my one child or two children, or you could divide it up, say 30%, 50%, 50%, right? Similarly, bills में भी आप delineate करते हैं कि किसके पास आपकी property जाएगी. Advanced directives में you express a clear intent that if something happens to me, where I'm in a situation where, for example, I'm in a coma, or I'm in a medical emergency where I'm not clearly able to express my opinion about medical care, then this is how I would like myself to be treated. Or this is the one or two people I would like to appoint who can decide on my behalf what kind of a medical decision needs to be taken. चाहे वो ventilatory care हो, चाहे वो intensive care हो, चाहे वो life prolonging treatment हो, right? So in the field of medicine, ideally, similar to how we have a will, we also can have an advanced directive, which defines who has the decision-making capacity if there is a medical emergency involved. Is that sort of clear? What is an advanced directive, right? Again, that is an ideal thing to do because in those difficult circumstances, it becomes confusing, right? मिर्जा गालिब को कितने लोग जानते हैं? Okay. तो मिर्जा गालिब जी ने लिखा है कि हम मरते हैं आरज़ू में मरने की, मौत आती है पर नहीं आती है. तो आप इसको कैसे इंटरप्रेट करते हैं? आप तो फिलॉसफी वाले स्टूडेंट्स हैं, अपनी तरफ से इंटरप्रेट करें. हाउ डू यू इंटरप्रेट दैट मिर्जा गालिब कपलेट? So loosely English में translation would be I die in the yearning of death. Death comes, but it does not come.
जब ज़्यादा परेशानी दुख होता है, then we can say this कि मरना चाहते हैं लेकिन मौत नहीं आती है.
हाँ, लेकिन जिंदगी मरने की. और
also when it comes, you are not aware that it has come, and after it comes,
right,
you don't know that your arzu has been fulfilled.
Right. So sometimes you might have some outstanding arzus of life.
No, even the arzu of death is not fulfilled.
Right, because it might not be the kind of death you want. Sometimes you don't know
because
whether
you are not aware that you are dead.
It is always yet to come.
Yes, there is always yet to come. Also, I mean, it might even be people are wanting to have a certain kind of death, but are not allowed to do it. In the sense, I want to have a peaceful death at home with my family. But if something happens where I have a road traffic accident and I'm taken to a hospital, I might be hooked onto tubes. I might be put in ventilatory care for 1 year, 2 years, 3 years. Maybe I will stay in coma. Maybe that's not the kind of death I had imagined. शायद मैं ये नहीं चाहता कि मैं अगर मैं उस सिचुएशन में हूँ तो मैं हॉस्पिटल में रहूँ, एक स्टेराइल रूम में रहूँ. शायद मैं चाहता हूँ कि मैं अपने घर में अपने फैमिली मेंबर्स के साथ रहूँ उस सिचुएशन में, राइट? सो वो भी एक इम्पॉर्टेंट हो जाता है इशू कि आप किस टाइप की लाइफ चाहते हैं. नाउ द अदर टर्म व्हिच कम्स अप इज यूथनेशिया, व्हिच बिकम्स क्वाइट, आपने भी सबने सुना होगा यूथनेशिया के बारे में. It comes from Greek terminology, which literally means a good death. Right? So you is good, right? Greek, and Thanatos is death. So euthanasia in that sense refers to a good death. Now, what is a how you break it down is a different issue. Right? So when we talk about terminologies, euthanasia usually is referred to when you intentionally administer a medication or any other intervention which causes a patient's death. Right? And ideally at his or her explicit request, with or without their fully informed consent. Right? So that's generally what euthanasia refers to. The other linked issue is withdrawal of life support. When you stop artificial measures of keeping a person alive, whether it is, say, artificial ventilation, people are hooked onto a artificial heart lung machine, or sometimes they are given artificial nutrition, because they are not able to eat, so they are either fed through a nasogastric tube or they are given an intravenous dextrose solution or any other way of keeping them alive. Then if that is withdrawn, then obviously that person will die because independent they are not able to support themselves. And the third issue is physician assisted suicide, where the physician will not actively give a medication. I will not inject the patient, but then will provide a set of medications which the patient can himself or herself take. Right? So providing access to the person so that person can take the decision whether they want to do it, and has access to that kit of medication which they can use. Right? So
this need not happen in case of a person who has a disease.
It could, yeah, so usually it is if there is ideally a disease, but then the interpretation of disease is very different. In some countries, any kind of person who is severely depressed would also qualify. Now that might typically in our understanding of disease, we might not think that is the right decision. But in other countries, they have said that anyone who's suffering, and that suffering it might be due to depression, due to loss of a loved one, is also considered disease, right? So it depends on what the jurisdiction allows in terms of qualifying criteria. Okay. Now, again, active euthanasia is when you prescribe medication or treatments which are aimed at shortening a person's life, ideally a patient's life, which is meant to alleviate their suffering. यहाँ पे एक्टिवली डॉक्टर या जो हेल्थ केयर टीम है वो ऐसा कुछ इंटरवेंशन करती है, चाहे वो मेडिकेशन देना हो या अ बंच ऑफ मेडिकेशन, अ कंकॉक्शन ऑफ मेडिकेशन दे रहे हैं, ताकि जो सफरिंग पेशेंट है उसकी लाइफ शॉर्टन हो जाए, डेथ जल्दी हो सके. Either so it might be a poisonous injection, it might be large doses of drugs. There is a limited dosage, a certain amount, say 10 ml is safe, but 100 ml is not. So a 10 ml is a normal medication, but 100 ml would be a fatal medication, right? With the intention of cutting short that person's life. The other form, where it is not an active intervention, is passive euthanasia. In which case, you will not do an active act, but you will withdraw support. For example, if someone is alive because they are hooked onto a respirator, as I said, a cardiothoracic machine, or is in an ICU setting, or is being given artificial nutrition, then you withdraw that care. You withdraw the respirator, you withdraw the artificial nutrition, then that person without that support will obviously die, right? So, यहाँ पे actively आप कुछ नहीं कर रहे हैं, आप actually withdrawal कर रहे हैं, जो उनका life supporting situation है, और जो inputs हैं, medical inputs हैं, and that what causes the death, right? Now a third form which is not typically talked about, but I think is an interesting one to talk about in our setting is, do we not practice societal euthanasia? आप सबको लगता है कि हमारी सोसाइटी में इस टाइप का यूथनेशिया होता है? महाराष्ट्र के ट्राइबल बेल्ट में मैलन्यूट्रिशन कितनी बड़ी इश्यू है, आप सबने पढ़ा? ट्राइबल सेक्ट जो डिस्ट्रिक्ट्स हैं, कौन-कौन सी हैं महाराष्ट्र के ट्राइबल डिस्ट्रिक्ट्स? Algar, Nandurbar, the malnutrition is a major issue. A lot of people have died. The other issue is farmer suicide. Why are farmers committing suicide in Gujarat? They have loans. They have had crop failure. There is drought, so they are not able to survive. They are being harassed by money lenders, right? In all of those cases, also because we don't have a social protection system, right? Because we don't have a system where those who are the most vulnerable in our society are able to be supported. Those who malnourished are not. Why is it in today's age of 2018 there are still small kids who are dying out of malnutrition? Why is it in today's situation that there are children who are dying of vaccine preventable diseases? So that is all because as a society we have not been able to intervene. We have not been able to provide them services when we should have, right, as a society. So in a way we have also practiced indirectly societal euthanasia, though we don't talk about it openly, right? Do all of you agree that this is true?
I don't think societal euthanasia will be a right term.
Okay, so what do you call it?
Nobody among us sanctions it. Like sanction means too hard a term here. Sanction means passing an order or doing something to get it done. Okay. Nobody in a society will sanction it, isn't it?
Sure.
There are some circumstances which let it happen, isn't it? It's not that the society sanctions it. While there is another case which makes it different. In euthanasia, if a person is is conscious enough, you at least need his or her consent and life. Here, the person who is malnutrition will be able to give his or her consent, but nobody asks for that.
Good point.
Also,
Others?
the euthanasia we are using in order to bring about a good death, which is in the end for the benefit of the patient who is suffering. This is not for the benefit of the person, of the individual at all. So,
Good point. Good point.
That point we can say that if somebody is malnutrition, then we would like to die.
that will be a very fancy
But actually, or maybe Manish is saying someone in the case of farmers suicide, why do most people commit suicide? Because they think कि अगर वो मर जाएंगे तो उनकी फैमिली पे एटलीस्ट वो डेब्ट का जो बोझ है वो नहीं रहेगा। उनको लगता है कि एटलीस्ट जो मनी लेंडर्स पीछे पड़े लाइफ के उनके शायद उनकी डेथ के बाद एटलीस्ट मे बी कॉम्पनसेशन मिल जाए गवर्नमेंट से, नहीं भी मिले तो शायद वो बोझ हट जाए। तो मे बी दे थिंक दैट इज अ good enough reason to die. Is that a right reason from a societal perspective? So great point. I mean, good point, good counter. But having said that, do we sanction it or not is a bit of a question mark for me. Because if we don't choose the right politicians who lead us, if we don't choose the right policy makers who don't prioritize health, education, nutrition, whose interest might be different, not on these basic social services, maybe they use other areas of interest, maybe roads is an area of interest for them, maybe buildings or infrastructure is an area, then also indirectly we are contributing to this issue. But any other thoughts on this? It's a good question to ask.
I think there is a difference between euthanasia and suicide. So I think the cases of farmer suicide should not be considered as a part of suicidal euthanasia, because euthanasia is led because of the unsuccessful attempts of curing terminally ill cases. Whereas in farmers' cases, farmers do not have such kind of situations, and it is more of socially responsibility comes in between, and also the farmer has more choice also. In the case of the farmer can live well if he is provided money or any assistance from government or from community as well.
Right.
So,
But if society is failing in them and doing that, then aren't we pushing them into it?
so that is why I don't.
You don't want to equate it in the same way as a
Farmer suicide or suicide should not be
equated.
equated with euthanasia.
Great.
Indonesia is now very standardized.
So I mean the basic definition we talked about is a good death, right? Right? In the medical scenario we talk about a certain set of criteria, but generally, so euthanasia by itself just means a good death. So if I say societal euthanasia, I'm saying a good death.
How do you define good
But
death? How you
this is
define
for
Exactly,
financial benefit of the
exactly. I am
family.
opening
There
it.
is another type of euthanasia, like prioritization. So without you taking food or
Okay. We'll come to that, sir. We'll come to that. It's a great. Okay, good. Glad that I got some discussion going on. Now, part of the reason people worry about is because they think there is a slippery slope. If there is euthanasia allowed, then it might be misused. In the sense that there is a family who has which is a very rich family, and there are 3 or 4 people who are waiting for the head of the family to die because then they can inherit the property. So there is a feeling that euthanasia might be misused. If someone is in a situation where they are not able to take their own decisions, then their heirs who might inherit that property might take advantage of the allowance of euthanasia to hasten their death, to make their death faster. Do you think that is a possibility? So is that something we should think in terms of
The case is going on currently in January 2018. That the US has passed this bill altogether at midnight 12, this was December. The inheritance tax has been imposed on. So even the cases are been seen. At the first year itself, that the grandfather was being sustained till 12 o'clock midnight, and then he was allowed to pass over into.
because they wanted to take advantage of that time frame?
And the rate of death also.
Question mark. Big question mark, because there are other people trying to take advantage. So do you think this is a valid concern when we're talking about framing laws or guidelines for euthanasia? How many of you heard this term? Thalai Puthal? No? Okay, how many cultures have this practice when you have a newborn baby of giving a good oil bath? Young infants, right? Almost all cultures have. ऑयल बाथ देके उसको अच्छे से नहलाते हैं ताकि बच्चा एक तो अच्छे से फीड लेता है और सो जाता है यूजुअली, और ये भी लगता है कि आप मॉइस्चराइज करें स्किन को, स्पेशली इन कोल्ड क्लाइमेट. नाउ इंटरेस्टिंगली इन सम पार्ट्स ऑफ Tamil Nadu, it has become a common practice where those families where the children are not able to take care of their older parents are practicing this form of killing their parents, and it's the same methodology, slightly different way of doing it. This is a small industry hub of Virudnagar, where many in many families this has been seen, and it's become sort of accepted cultural practice. It's not like you have to hide and do it. Community members will come before the day when this event will happen. They will come and meet that individual, pay their last respects. If there is an incident, then they will try to hide it. अगर पुलिस investigate करने की कोशिश करती है तो community से कोई बात नहीं करता है. So it's a very interesting cultural practice. So usually an extensive oil bath is given to that elderly person, right, before the crack of dawn, early in the morning. Then for the rest of the day, they are given a lot of cold, tender coconut water. Right? Now mostly we think coconut water is good. Many of you, when it is summer, will stop and get a green coconut and you will drink it. It's a very refreshing. But if you do too much of it, then it can cause renal failure. And especially if it is an older person, then there could be a situation where their kidneys could shut down, or they will get a fever, and because they are already old and their immunity is low, many of them succumb very quickly. कई बार ये होता है कि अगर इससे भी नहीं मरे हो तो वो मड का एक कॉन्कॉक्शन बना के उनको फीड कर देते हैं, या फिर उनको खाना नहीं देंगे काफ़ी टाइम के लिए, या जो क्वैक्स होते हैं उन विलेजेस में उनसे नीडल इंजेक्शन दिलवाते हैं उस फैमिली मेंबर्स उनको. So again, this is happening. There is a cultural practice also in some of our settings, right? So again, we talked about the fact that we would have some concerns about the possibility of misuse and a slippery slope. Here is a practical example of how it is already happening in some parts of the country. Again, sir, आपने बात की थी इसके बारे में. Jains have this practice of Santara. Has everyone heard about it?
Yes.
Right? Actually, there are sometimes media reports. These individuals who practice Santara actually become celebrities. Maybe you will read about it that they fasted for 100 days, 120 days. People will come, they will almost worship them. If and when they die, उनकी समाधि बनती है, उनको एक procession में लेते हैं. It's considered as a superhuman thing to do. That you have the mental strength to be able to starve yourself to death. Right? So similarly, in Hindus, lesser known, but there is this allowance of a practice, which is Prayogaravashya, which is essentially ending your own life by stopping any kind of feeding. Usually people start off by stopping all solid feeds and then slowly also stopping all liquid feeds. Again, it's not very common, but it's not very uncommon. But again, this is one area where the law is a bit silent, because in other cases you have sections of the Indian Penal Code which usually were criminalizing suicide, until very recently where there has been a bit of a decriminalization. But obviously this is a form of committing suicide, but usually because it's couched in religious, cultural terminology and practice, usually the law does not step in unless someone would take in, would file a case. And where it becomes controversial is when it's not the very old who decide to do it. अगर कोई 16 साल का लड़का या 17 साल की लड़की डिसाइड करती है कि मैं संतरा लेना चाहती हूँ, तो उस टाइम पे थोड़ा सा ग्रे जोन बन जाता है, क्योंकि अगर कोई 70-year-old वो डिसीजन लेता है तो शायद हम लोग थोड़ा सोचते हैं कि that person has lived a good life. But what if a 16-year-old decides to do it? What if a 17-year-old? What if a 21-year-old who's just married decides to take it? That's where it becomes a bit of a grey zone, and that's where this issue of what constitutes a good life, what constitutes a decision about taking one's own life becomes a bit more complicated. So let's talk in terms of the legal realm. What are the laws related to some of these decisions? So one is section 92 of the Indian Penal Code, which talks about act done in good faith when done without due consent. So you have participated in an act which you think is for the benefit of that person, but it's not with the consent of that person. Section 300, 300 and 302, both are linked with murder, right? And so actively ending someone's life. That can also come in when you're talking about euthanasia, for example. Voluntary euthanasia में एक exception होता है section 300 में, which is talking about not culpable homicide. Section 304 talks about punishment for culpable homicide, and section 305 and 306 are for abetment of suicide. Right? So all of these become operative when you're talking about all of those elements of euthanasia or physician-assisted suicide. All of these could play and could be legally imposed on a particular case. Section 306 में there is a clear delineation of the kind of punishment someone could undergo, right? whoever abets the commission of suicide shall be punished with imprisonment for a term which may extend up to 10 years and shall also be liable to fine. So इतना strong अगर आपको sentence मिल सकता है तो obviously people will be worried that if they participate in any act which might be read as abetment of suicide, then they might be tried, including medical professionals, right? Which is why you see them being very, very afraid of such circumstances. 309, which is attempt to commit suicide, as I was saying earlier, was criminalized, now has been, to some extent, mildly decriminalized, but again, might be pushed in, where someone who attempts to commit suicide might also be tried against. Now, fundamentally, it goes into the rights which are enshrined in the Constitution. So, Article 21 is right to life, right? Which is the protection of life and personal liberty, and that no one should be deprived of that right. Now, one argument which has been made in Section 309, which is committing suicide, is that it's violative of the right to life. Because the argument they make is, if you have the right to live a life, then you also have a right not to live a life. Which is in the sense that if I have the right to have a fulfilling life, I should also have a right to take my life away. That's the counter argument to having a Section 309. But the courts have ruled against that, saying that just because you have a right to life does not automatically mean that you have a right to take away your own life. So there is a Supreme Court ruling in 1994, the famous Ratinam case, where they talk about the fact that you have to take a few positive acts to take away your life, and those acts are not condoned under the right to life of the Indian Constitution. So you cannot consider the right to suicide in the same parlance as the right to life. This is the legal interpretation. Whether it's right or wrong is a different story, but that's how the law reads it right now. There was another case which was in the state of Punjab, again in 1996, the Jian Kaur case versus the state of Punjab. Again, the judge in that case, again this went all the way to the Supreme Court, said that permitting termination of life in the dying of those who are in vegetative state is not compatible with Article 21. So you can't argue on the basis of Article 21, the right to life, that someone who is in that stage has the right to terminate their life. Again, right? So be very conservative cases in that. Another case, 2004, was the K. Venkatesh case. K. Venkatesh was an individual who had end-stage muscular dystrophy. Muscular dystrophy is a condition where your muscles slowly degenerate, waste away, and then it's a kind of a painful death because you lose control over your bodily functions, you're not able to breathe independently. So Venkatesh actually appealed to the courts and said that I know that I'm going to die, but there is one wish that I have, that I be able to donate all my organs. I want to see that happen so that I'm able to help someone else. I know that I'm going to anyway die, but I would like to see my organs donated. And he said that that was his life's ambition. But unfortunately, the court did not agree with him. They said that euthanasia for the purpose of organ donation in his case was not acceptable. Right? And even after he had died naturally, which happened actually around 10 days, after 7 days of when this court case had been filed and there had been a hearing, the court still disallowed organs to be harvested. And the reason there was because he had died naturally, so his heart had stopped working. Right? So typically, we remember that whenever there is an organ donation in India, it can only happen under the Transplantation of Human Organs Act, which requires that the person be brain dead, as certified by a panel of doctors, usually involving a neurologist, but the heart has to be beating, right? Because the rest of the organs are supplied blood by the heart, so the organs have to be working in terms of at least there being the active arteriovenous pumping of blood, because otherwise the organs won't supply, right? Oxygen needs to go to those organs to be able to survive. But since he had died naturally, which means that his heart had stopped working, his organs were not retrievable for donation purposes. So in that sense, his wish was not fulfilled, because the only way that would have been true was if he had undergone brain death and his heart was still beating, but that was not the case. So this is also where there is an intersection between the Human Organ Transplantation Act and the whole issue of end of life. This is the one case. There is a very famous Aruna Shanbha case. How many of you have heard of Aruna Shanbha?
Yes.
So tell us a little bit, for those of us who don't know Aruna Shanbha, उसके बारे में बताएं थोड़ा. Who was Aruna Shanbha? What is the case about?
हॉस्पिटलमध्ये जे सफाई कामगार होता त्याने तिच्यावरती रेप केलेला त्यामुळे ती आणि खूप मारलेलं पण तिला त्यामुळे जेव्हा ती त्या अवस्थेमध्ये भेटली इतर लोकांना तेव्हा म्हणजे जगे कमाले याच अवस्थेत होते तरी पण त्यांनी खूप वर्ष काढली मग नंतर ज्या त्यांचं सांभाळ करत होत्या त्या म्हणजे एखादं नाव पण येत होतं तर त्यांनी मग कोर्टामध्ये पण हे केलं की दयेची याचना केली की त्यांना मृत्यू देण्यात यावा म्हणजे ते सगळं
So Aruna Shanbha was a nurse in the state, in a state hospital. KM hospital का नाम सबने सुना है, famous hospital, right? Where she was working as a nurse. Her shift had ended and she was going into the parking area. A hospital attendant attacked her, raped her and strangulated her. So when she was discovered, she was already in a, because she had been, उसका गला दबाया गया था एक dog chain से, so she had already received brain damage because of a lack of oxygen supply to her brain, and she was in a vegetative state. She suffered brain damage obviously because of this incident, and since then was in a vegetative state. So this is again 1973. She was in her mid-20s. Okay. Now she, since then, since 1973, the staff of KM Hospital had taken care of her. She was put in a side room of one of the general wards of the hospital. All staff of the hospital considered her a member of their family, and so she was taken very good care of. Almost in 42 years of being in hospital, उसको एक बार भी bed sore भी नहीं हुआ. Right? Typically जो long term care जिनको देना पड़ता है, especially जो vegetative state में होता है, bed sore काफी common complication होता है. But उन्होंने obviously इतनी dedication से उसका ध्यान रखा कि उसको एक बार भी bed sore भी नहीं हुआ. But at the same time, she was in a persistent vegetative state for close to 42 years. So a journalist called Pinky Virani filed a case saying that she is actually having no quality of life. If we are just prolonging her life without reason, she might actually be suffering. And let's constitute a medical panel which looks and finds out what stage of consciousness, if she has any or not. And if not, then we should withdraw care so that she is able to die peacefully, right? Now this case had gone all the way to the Supreme Court. In this case, the Supreme Court decided that the journalist had no locus standi. Simply, journalist has no direct correlation with this patient. The people who have cared for this person for the last 40 years is the community of nurses of that hospital, who considered her a fellow nurse of theirs as a family member and had taken care. And whatever, in that sense, were the closest relatives who could take a decision about her life or not, right? And in that case, refused Pinky Virani's application for withdrawal of life care if there was medical reasons to do it. But Aruna Shanbha actually died 4 years later. This court case happened in 2011. In 2015, she died of pneumonia. 42 years she had spent in that persistent vegetative state, living in that hospital. Now, at the same time, what the Supreme Court did in 2011 when this case was happening was actually talk about an elements of situations where passive euthanasia might be allowed. So in a sense, they came out with a set of guidelines which said essentially that ideally this decision is a decision which the legislation should take. In the sense, the parliament should enact a law which defines the contours of what is acceptable in the euthanasia debate. They were opposing active euthanasia, but in terms of passive euthanasia, they said the legislature should adopt some elements of what are allowable guidelines, and this should be written into the law so that there is no confusion. But they said till the law is enacted, these are some guidelines which need to be followed. This decision should be taken either by the parents or the spouse or any other close relative. If any of these are absent, then it can be taken by a person or a body of persons who is acting as a next friend. So in case of Aruna Shanbha, it was the nurses, for example. It can also be taken by doctors attending the patient. However, it should be done in the best interest of the patient. Right? So this was guideline 1. Guideline 2, even if such a decision is taken by any of these individuals or groups of individuals, it has to be ratified by the High Court of that area. Right? So when such an application comes to the High Court of that area, then the Chief Justice of that High Court would constitute a bench of High Court judges who would decide whether to grant approval for passive euthanasia or not in that particular case. So they would appoint a panel of doctors, the doctors would come up with the report which is submitted on the condition of the patient, and all the close relatives as well as the state would be informed before a final decision was taken. Right? So this was sort of the set of guidelines which came through as a result of the Aruna Shanbhag case in the Supreme Court. But in 2014, the Supreme Court went back on that decision partially, saying that unfortunately what has happened in that 2011 decision is that at one side we said that our legislature is the one which should decide, and on the other hand we also came out with guidelines about passive euthanasia. So that they said this is mutually not compatible. एक तरफ से आप बोल रहे हैं कि पार्लियामेंट डिसाइड करना चाहिए कि पैसिव यूथनेशिया कैसे होना चाहिए या नहीं होना चाहिए, और दूसरे साइड पे हमने सेम जजमेंट में ये भी लिख दिया कि ये सारे क्राइटेरिया होने चाहिए पैसिव यूथनेशिया के, तो ये कंपैटिबल नहीं है एक दूसरे से. आप गाइडलाइंस भी डिफाइन कर रहे हैं और एट द सेम टाइम आप बोल रहे हैं कि लेजिस्लेचर को डिफाइन करना चाहिए. So they said that this should be referred to a constitution bench, the Supreme Court, which is typically a larger bench, a 5 to 7 bench of the Supreme Court. That is still not complete. That process has not yet been completed. But so we are in a bit of a hung jurisdiction as to what exactly happens. Okay, so that's sort of the legal area. Now let's talk about some of the practical areas around end of life care. Right? So dying can again be a peaceful event. Some of us are lucky to have that. It's just a peaceful death, or it could be a death where there is a lot of agony, a lot of suffering, when there is inappropriate sustenance or by life support. So as I said, part of the reason why we get stuck in those situations is because the physician is fearful of being falsely accused of providing suboptimal care, because they might be civilly prosecuted, they might be criminally prosecuted if they withdraw care, if they don't provide active care. Part of the reason is that we don't have clear legal guidelines or ethical guidelines around how to treat such patients. Self-determination, our right to decide how we should be treated in a medical setting is not very well enshrined in the Constitution. So part of the challenge, as we started off by saying advanced directives are a good thing, one of the challenges that the law does not clearly recognize advanced directives. आप advanced directive लिख भी दें, so will they be legally recognized if a situation comes is a bit unclear. You might put it, you might actually get it on a stamp paper, but whether that be followed is a bit of a gray zone. That becomes an issue. And so a dignified death is a bit unclear in the Indian current constitutional framework. The other issue, as we were discussing yesterday, and I think it was also discussed day before, is that physicians typically, in your medical training, we are all trained to save lives. We are not trained to actually take decisions in situations where it might be acceptable to withdraw treatment or to stop treatment. We are all trained to be aggressive in our treatment strategy. कुछ भी हो जाए, patient को बचाना है. उसमें ये नहीं सोचना है कि quality of life is a minimum criteria. The active criteria is the patient बच रहा है कि नहीं. चाहे वो machines पे बच रहा है, चाहे उसको बहुत सारा active आपको intervention करना पड़ रहा है जिसके कारण वो uncomfortable. That is not your primary criteria. Your primary criteria is saving the patient. Right? That is how most doctors are trained. So it's more on curing or saving lives rather than the comfort element of that person. It's also expected that you do your best, right, for that patient. That's what is expected. And again, people are afraid of being possibly criminally liable because there are laws about that. The other issue is this whole thing of we generally tend to respect the medical profession. So अगर ऐसी कोई situation आती भी है, तो एक deference हो जाता है. डॉक्टर आप जो भी बोलेंगे वैसा करिए. अगर आपको लगता है कि जान बचा सकते हैं तो आप प्लीज कुछ भी कर सकते हैं तो करिए. That kind of dialogue does not happen where you ask the doctor or have a chat with the doctor or ask questions and say what is the plus minus of doing that, what kind of quality of life will my parent have or my loved one have. That kind of usually conversation does not happen because there is a deference to the medical profession usually in our settings. Is that sort of clear? आप लोग मानते हैं कि ऐसा होता है? यूजुअली हॉस्पिटल सेटिंग में जो डॉक्टर बोलते हैं, या कई बार डॉक्टर को ही बोला जाता है कि आप ही डिसाइड करिए, आप जो भी कर सकते हैं करिए उस सिचुएशन। So the issue then becomes कि and this is something we have dealt with a couple of times since yesterday also. What is the kind of death that we want? If you and I were to die, what is it that we would expect to happen? What is it that we would expect our loved ones to do? Right? So when it is time to die, would we want that our own doctors and families decide to do what they should be doing? हम ये चाहेंगे कि हमारे जो डॉक्टर्स हैं और फैमिलीज उन्हें वो करना चाहिए जो उन्हें करना चाहिए, राइट? वर्सेस वो क्या कर सकते हैं अगर वो करें. सो देयर इज अ स्लाइट क्वालिटेटिव डिफरेंस. उन्हें क्या करना चाहिए वर्सेस वो क्या कर सकते हैं, राइट? करना चाहिए इज अ बिट ऑफ अ moral, ethical, spiritual element to it. वो कर सकते हैं has an active intervention element to it, saying कि yes they can prolong our life, yes they can put us on machines, yes they can put in treatment which will make me live for longer but might not increase my quality of life or might still put me in a very painful situation. Yes I am alive but I am living a very painful life. So that वो कर सकते हैं उस तरह की चीजें, but क्या उन्हें वो करना चाहिए is the kind of quality of death that we should be having, right? So do you understand the difference between what they should be doing and what they can be doing, right? That's the difference that we are talking about in terms of the kind of death that we want. In terms of where we want to die, you want to die in a hospital setting where you are surrounded by machines, a white room with foreign faces hooked up to machines, versus wanting to die in your familiar bed with your family around you. Or in a place where you now maybe you grew up in a village. आप जाना चाहते हैं अपने गांव में जहाँ पैदा हुए थे, जहाँ आपने अपना बचपन बिताया, आप चाहते हैं कि वहाँ पे जाके आपकी डेथ हो, वर्सेस आप एक फॉरेन सेटिंग में जहाँ कभी नहीं गए हैं, एक ऑलमोस्ट स्केरी सेटिंग हो जाता है. चारों तरफ से सिर्फ आपके पास वाइट गाउन्स वाले दिख रहे हैं और सिर्फ मशीन्स की आवाज़ आ रही है, चारों तरफ से आपके अंदर ट्यूब्स घुसे हुए हैं. उस टाइप की डेथ आप चाहते हैं वर्सेस अगर आपके पास वो चॉइस हो तो आप किस टाइप की डेथ चाहेंगे, वो क्वेश्चन है. So where do we start looking at these kind of decisions? अगर हमें उस टाइप के decisions लेने हैं तो हम कहाँ देखना चाहेंगे? तो एक constituency डॉक्टर से पूछें कि आप किस तरीके की डेथ प्रेफर करेंगे अगर आप मरने की कोशिश करोगे, क्योंकि वो तो डेली देखते हैं डेथ को, तो आपसे पूछे कि आप कैसी डेथ चाहेंगे. तो इट्स इंटरेस्टिंग. आई डोंट थिंक इंडिया में इस पे स्टडी हुई है. आप लोग कई लोग स्टूडेंट्स हैं, मे बी इट्स अ गुड रिसर्च टॉपिक टू डू, बट यूएस में एक बार स्टडी हो चुकी है और स्टैनफोर्ड यूनिवर्सिटी में स्टडी हुई थी. उन्होंने पूछा डॉक्टर से आप किस टाइप की डेथ चाहेंगे और 90% सेट कि हम एक कंफर्टेबल डेथ चाहेंगे. हम ये इस टाइप की डेथ नहीं चाहेंगे जहाँ पे इंटेंसिव केयर हो, जहाँ पे हमको रेससिटेट करते हैं अगेन और एग्रेसिव ट्रीटमेंट दे. उस टाइप की डेथ हमें नहीं चाहिए. हमें एक कंफर्टेबल आइडियली एट होम इन अ फैमिलियर सेटिंग काइंड ऑफ डेथ चाहिए. तो अगर डॉक्टर्स जो ये डेली देखते हैं 90% ऑफ देम आर टॉकिंग अबाउट दैट काइंड ऑफ अ डेथ बीइंग अ गुड डेथ फॉर देम, then it is something for us to reflect on the rest of us, because they have seen probably this happen much more common than anyone else's, right? So this is where how can we start having those conversations comes in. One is clinical mediation के through हो सकता है अगर हमारे पास वो avenues available हो. You have had a workshop on clinical mediation a couple of years ago where you encourage a platform where these kind of conversations can happen. You could have clinical ethics committees in hospitals. क्लिनिकल एथिक्स कम्युनिटीज में आपके एडमिनिस्ट्रेटर्स भी होते हैं, एक लीगल रिप्रेजेंटेटिव होता है, यूजुअली थियोलॉजियन होता है ऑफ व्हिचएवर फेथ यू वांट. Doctors are involved, family members are involved. Everyone comes together and discusses the case and takes a decision. But also having the possibility of not a hospital but an intermediary kind of a place which is more comfortable, a palliative care center or a convalescence home, right? Have any of you heard of palliative care centers in India?
Yesterday only mentioned.
There's also one in Pune, in Varjhe, run by Cipla. There is a Cipla palliative care center. If you go on the Pune-Bangalore highway and you cross the Varjhe area, आपको एक साइड में दिखेगा, लेफ्ट साइड में एक बड़ा सा बोर्ड लगा हुआ है जहाँ पे होता है. बैंगलोर में एक बहुत फेमस पैलिएटिव केयर सेंटर है जिसका नाम करुणाश्रय है, जहाँ पे भी एंड ऑफ लाइफ जिनकी हो जाती है, जो लोग फॉर एग्जाम्पल टर्मिनल कैंसर के पेशेंट्स हैं या टर्मिनल इलनेस के पेशेंट्स हैं, जहाँ पता है कि उनको एक्टिव मेडिकल मैनेजमेंट से कोई फ़ायदा नहीं होगा, बट उनको सपोर्टिव केयर चाहिए, पेन रिलीफ चाहिए, वो जाके उस सेटिंग में जाते हैं जहाँ पे जो इंटरवेंशन होता है वो लाइफ को बचाने के लिए नहीं होता है. There is no active medical intervention to save them. It is to give them a peaceful, ideally as much as possible painless death. Right? So you support them, you give them food to the extent that they can have, you provide them medication so that their pain is reduced. Right? That is a different setting than an active medical intervention setting. So maybe we need more of those. Hospitals तो हर जगह आ रहे हैं, हर 1 किलोमीटर में 3-4 नर्सिंग होम आने लग गए हैं आजकल, बट वो ऐसे टाइप के सेंटर्स कहाँ आ रहे हैं, जबकि ऐसे सेंटर्स की जरूरत है. तो वहाँ पे अभी हमको आई थिंक एज अ सोसाइटी सोचना चाहिए कि हम किस तरीके के ऐसे सेंटर्स को कैसे बना सकते हैं. So where is it that we need to start having those conversations so that we can get more people to think about these issues. कुछ तो medical conditions हैं जहाँ पे पता है कि वो situation arise हो सकती है. जब ऐसी कोई situation आ रही है medical तो फिर obviously वो end of life discussion spark off हो जाने चाहिए. एक है अगर एडवांस स्टेज है, किसी के पास एडवांस COPD है जहाँ पे एक्टिव ऑक्सीजनेशन की जरूरत पड़ रही है, कैटास्ट्रोफिक इलनेस हो गई किसी को, प्रोलॉन्ग कोमा में है, कोई पर्सिस्टेंट वेजिटेटिव स्टेट में, इनक्यूरेबल क्रॉनिक सिवियर न्यूरोलॉजिकल डिजीज है, प्रोग्रेसिव मेटास्टैटिक कैंसर हो गया, रेस्पिरेटरी अरेस्ट हो गया, या आप कोई भी ऐसी सिमिलर सिचुएशन जहाँ आपको डॉक्टर आपको बोलते हैं कि सर्वाइवल के चांसेस लो हैं. All of these situations are situations where at least these conversations should start, and you should start anticipating the need. Now within palliative care you have multiple choices, right? It is not that you have only one way to decide what kind of palliative care to undergo, right? So and usually it's up to the patient, one, or the family or loved ones to decide what kind of palliative care should be provided. So there is multiple elements. One is you offer palliative care with full support. So they are given circulatory support, you are given metabolic support, you are given nutritional support, you are given ventilatory support, which is artificial respiration. Or you have a clear criteria that you will provide support, but if that person requires resuscitation, that will not be offered. So कल का जो केस था, डॉक्टर ओलिंडा ने बात की, do not resuscitate. अगर कोई cardiac arrest में जाता है तो हम resuscitate नहीं करेंगे, we will let that person die. You could have an active requirement of withholding of life support, which means that if someone has the requirement for a ventilator, that is withdrawn, or you withdraw life support. Any parenteral nutrition, any nutrition being given artificially is also withdrawn, so that person dies. And then you might have pure palliative care, which is usually what happens. Pain relief देते हैं, या basic care देते हैं, care of the patient. Now there is also a position paper which has come out by the Indian Association of Palliative Care, which talks about the need for the kind of policy that we should be having. So they have defined some principles of a good death, right, which ideally both for patients and providers should be there. One is that you should ideally know when death is coming and to understand what can be expected. कब expect कर सकते हैं next 1 week में, next 1 महीने में, next 3 महीने में, next 6 महीने में. If you have advanced cancer, that might be true. To be able to have some degree of control on how that death will happen and in what setting that death will happen. That death be a dignified death in a private setting of your choice. You have access to pain relief and other symptomatic control so that it's not a very disturbing death. You have a choice of where you want that death to occur, whether you want it in a hospital setting, in a palliative care setting, at home with your loved ones, your choice. To have access to information and expertise to be able to take that decision. To have access to any spiritual or emotional support. You want to have a discussion with your priest, with your chaplain, with someone you respect, someone you have great respect for as a spiritual leader. To have access to hospice care, which is palliative care. To have control over who is present when you die. You have a couple of loved ones, you don't want 20 people in the room, you want 2 or 3 people who matter to you to be present when that happens. To be able to issue advanced directives about decisions in that regard. To be able to say goodbye and control the timing. It might be the case कि मैं चाहता हूँ कि X day पे, the 11th of January पे in a private setting death हो 3 लोगों को उस रूम में. But ये there is a large social circle. I want to be able to say goodbye to them. So leading up to that 11th of January, I say that I want to meet everyone, whoever is available, at my choice. I have visitation hours where I talk to them and say goodbyes, right? To be able to, as much as possible, have control over when that death happens without it being prolonged. On this. Yeah, I'm almost done with this element and then we will try it with that. Components of good death would include pain and symptomatic management, clear decision making, preparing for death, the completion of anything you think are pending tasks. For example, you have not made a will, you want to make a will before you die. Feeling a sense of completion about contributing to others, and affirmation as a whole person who has taken those decisions. In terms of steps involved in providing a good end of life care, doctors are expected to recognize when there is the start of a process where you know that the patient is dying. You need to institute an end of life decision making process. You need to talk about palliative care where there is required after death care becomes important. कई बार हम लोग ये बात करते हैं सिर्फ पेशेंट के बारे में बात करते हैं, बट तो बाकी जो फैमिली रह जाती है उनको भी एक स्टेज ऑफ ग्रीफ, मल्टीपल स्टेजेस ऑफ ग्रीफ अंडरगो करनी पड़ती है. So part of preparing for end of life is also planning a bereavement process for the family, so that when that person dies, the family members, the loved ones who survive, are able to be provided counseling, support, so that they can also, deal with those with the emotions that they are having. That's also an important component of end of life. It's not just for the person, but also for those who are surviving. So the guiding principles again are symptomatic control, preferred place of care, safe and secure, carers feeling supported and provided bereavement care, healthcare staff being confident about how they are doing it with a sense of teamwork, the family feeling prepared, educated and supported about such a decision, the team being accepting of such a situation, anticipating it and also providing information and support as much as possible. So is that care set up in terms of end of life sort of principles and how it should operate? Any questions?
Sir, please kindly explain the term chronic vegetative stage means.
So chronic vegetative state, one example is what Aruna Shamla was undergoing. Someone who is alive but has no sense of consciousness, in the sense that person is living but वो stimuli आप उसको देंगे, pain stimuli वगैरह देंगे तो थोड़ा सा reaction होगा. Are they really feeling anything? Are they able to perceive कुछ भी naturally वो कर पाते हैं नहीं कर पाते हैं? तो वो almost एक persistent vegetative state, इसलिए हम vegetative use करते हैं कि almost एक vegetable की तरह है. मतलब जिंदा तो है but any of the elements yesterday we were talking about what it means to be alive. Any of those elements are not satisfied. Some kinds of coma, some forms of coma they might still have pain को वो respond करते हैं, लेकिन persistent vegetative state में कई बार pain को भी respond नहीं करता, artificially pain induce करेंगे तो भी वो respond. Other questions?
Our donation, you said that the patient will take one, but eye donation and skin donation after this.
Yeah. So in the large, more solid organs, that is where the brain death criteria becomes more operative. In some kinds of death, like the ones you described, within a certain number of hours after your heart stops beating, it could still potentially, but there also you have to have certain care, like you keep that area moist, eyes को moist रखें, इसलिए वो cotton रखने की बात करते हैं. Yes, you are. थोड़ा सा.
Sir, is active euthanasia legal in any country or anything?
In some jurisdictions. So Switzerland, Netherlands, Belgium, parts of the US. Again, it depends on. In some cases, it's more like physician-assisted suicide. In some cases, it is active euthanasia. But again, with very clear, defined guidelines as to what qualifies. There has to be a waiting period. It's not like आप डॉक्टर के पास जाएंगे और डॉक्टर को बोलेंगे कि मेरे को यूथनेशिया चाहिए और कल यूथनेशिया हो जाए. There has to be a waiting period. There is a counseling process. There has to be a documentation. There has to be a clear reasoning as to why it's being done. There has to be a clear satisfaction notice to official authorities. There is a whole defined set of criteria. There are also organizations which provide euthanasia services. Like there is an organization called Dignitas in Switzerland, which offers a care home which just offers euthanasia services. So sometimes people go to Dignitas in Switzerland if they are not allowed to undergo euthanasia in their own countries. They access it in Dignitas because it's allowed. So, but I think it's a bit controversial. Many other people are uncomfortable with that. But some countries consider themselves to be more progressive and accepting of euthanasia being an option.
Conceptually, is there really a difference between voluntary active euthanasia and physician-assisted suicide?
Well, it's only who is the active actor. That is the main difference. Ultimately, the intent is the same. The intent is the same, but the actor changes. And again, for the doctor concerned, in a case where there is legal chance of being tried under criminal prosecution, it's also the difference between murder and abetment of suicide.
So do we really have instances of physician-assisted suicide?
At least not officially reported. It might be true that in private circumstances people do it, but not officially. It's not officially because it is not acceptable.
Sir, can you focus on surrogacy and cloning?
Sure, but should we do that one-to-one later? Because I think that's a slightly different issue, not related to end of life care. Let's have a conversation. Over lunch, I'll speak to you about stuff.
It's not related.
Sure. Other questions? Because otherwise we'll break, but we'll break with some group work. Because I think the workshop is coming to an end. I think Harish has worked with his colleagues a lot, very hard in putting together a whole panel of speakers, and hopefully it's been useful. But it will only be useful if we have some clarity around it, if we have all understood. ठीक है? तो 4 ग्रुप्स बनाएंगे, ठीक है? Group A, Group B, Group C, Group D. Okay. So should we do that now? A, B, C, D. Should we just do that geographically? Or should we mix all of you up? Mix करें? नहीं mix करते हैं. Mix से क्या होता है वो सारे faculty एक side हो जाएंगे. Okay. So the way to do it is when you keep saying A, B, C, D. Right?
Yes.
सर आप पार्टिसिपेट करेंगे? हाँ, अभी के लिए. अब A, D, starting again with A. All of you have cameras with picture phones with camera. Just take a picture. Give it 15-20 minutes is enough. Right? So it's around 12:25. So we'll reconvene at 12:40. Right? And then 5 minutes each, and we should be done by 1:10. Okay? Okay?
A and B group will go.
A and B here in this room, A this side, B that side, C in the room where they typically serve lunch, and D in this classroom. Okay? So please.
काही वेळा न्यूबॉर्न बेबीच्या बाबतीमध्ये अनासिमेटिक असतात किंवा डाऊन सिंड्रोम असतात. ॲक्टिव्हिटी इज बेटर ऑप्शन. फॅसिलिटीशिया हा बेटर ऑप्शन नाही होणार.
What kind of change in Indian law would you like to see?
आणखी काय ज्ञानेश्वराची समाधी घेतली हे पण त्याच्यात येतं. समाधीचं म्हणजे स्वतःहून घेतली ना समाधी.
आता त्याच्याकडे कसं आपण पाहतो
नाही पण त्या वानप्रस्थापश्रमामध्ये शेवटी काही पाणी सोडायचं, मग अन्न सोडायचं, असे पण काही शेवटचे प्रकार आहेत. त्या पद्धतीने सुदृढ मनुष्य अशा पद्धतीने पेनफुल जे डेथ असतं ते सेलिब्रेशन डेथ असतं.
What we would like to have in our society, in judiciary system.
I'm talking about the first question, only about the first.
Both are interrelated.
Let us think about the reasons of passive euthanasia. Why we want passive euthanasia? Why passive euthanasia is better option than the active or physical assistance?
लोकांच्या मध्ये अजून कोणाच्या म्हणजे इन्कम आलेलं नाही, कोणाला आजार झालेला नाही, अशा परिस्थितीमध्ये जर तुमचा अवेअरनेस थोडासा जर निर्माण झाला, याच्याबद्दल चर्चा जर झाली तर जास्त सोपं होईल.
अजून एक अशी
म्हणजे अवेअरनेस हा मीडियामधून आपण करू शकतो.
अजून व्यवस्था अशा उपलब्ध करून देता येतील की ज्यांना घरी एंड ऑफ लाईफ केअर द्यायचा आहे आपल्या पेशंट शकतात. त्यांना घरी त्या सोयी उपलब्ध होऊन देण्यासाठी समाजातल्या काही इन्स्टिट्यूशन्सनी पुढे येऊन तशा सर्व्हिसेस ऑफर करणं हे खूप महत्त्वाचं आहे. आता आपली इच्छा खूप असते की आपण घरी न्यावं पेशंटला, पण घरी त्या सोयी उपलब्ध नसतात.
रेझिंग फंड्स बोलता येईल, पॅलेट
इन्स्टिट्यूट्स फॉर
अदरवाइज टू सपोर्ट द पॅलेटिव्ह केअर असं माझ्या बरोबर
एनजीओ
नाही मनाच्या तरी होता असं आहे की मध्ये हॉस्पिटल नाही आहे.
कारण शेवटच्या क्षणी तरी आपण म्हणजे आपल्या माणसांबरोबर एकत्रित राहावं,